Welcome to the What Family Physicians Need to Know About Latent Tuberculosis Infections, LBTI. Today's presenter is Dr. Henry Fraimow. Dr. Fraimow is an infectious disease specialist at Cooper University Hospital and associate professor of medicine at Cooper Medical School of Rowan University in Camden, New Jersey. Dr. Fraimow has over 25 years of experience in management of tuberculosis infection and disease and serves as the senior medical consultant for the Southern New Jersey Regional Specialty Chest Clinic in Belmar, New Jersey. He also serves as a consultant panel for the TB Regional Training and Medical Consultation Center at the Global TB Institute at Rutgers in Newark, New Jersey, providing TB medical consultations to providers throughout the Northeast region of the United States. I'd like to turn the presentation over to Dr. Fraimow.
Thank you for the introduction. Good, I guess it's afternoon now, and we're going to be talking about latent TB infection in what we like to consider the beginning of the era of TB elimination in the United States. And the focus of this is what family physicians really need to know about latent TB infection. We will be starting with a brief case here. Let me just get my clicker working here. Here we go. So just to sort of frame some of the questions we'll be talking about, this case is a 62-year-old US-born physician. He had a TB skin test or tuberculin skin test done during his residency in New York City back in the early 1980s. And he never received treatment. He has a chest x-ray that's read as normal. He's healthy. He takes a statin for hyperlipidemia, and he denies any symptoms. So we have some questions about this person. Does he have latent TB infection? If so, should he be treated for latent TB infection? If he's going to be treated, who should be treating him? And what regimen would you treat him with? Okay, so using this to frame sort of the discussion, these are our learning objectives for this webinar. First, we're going to start off with a brief overview of the natural history of TB infection, and so that everyone is clear about the distinction between TB infection and TB disease. Then we're going to look at the epidemiology of tuberculosis and what that means and the implications for what the U.S. public health approach to TB infection and disease is here in 2019. We're going to talk about the tests for diagnosis of TB infection, including skin testing and the interferon gamma assays. We're going to talk about the evaluation of someone who has a positive tuberculosis test. We're going to talk about who is at the highest risk for progressing from having latent TB infection or LTBI to developing TB disease. And we're going to talk about the current options for the treatment of LTBI, which may be different than what you are used to from the past several years. All right, so let's talk a little bit about the natural history of TB infection. The first thing that happens is that tuberculosis is inhaled by somebody who has never seen tuberculosis before, somebody who we would say is a naive host, and they breathe in those tuberculosis germs, and then they settle deep in the lung. So what happens next? Once those organisms settle deep in the lung in the alveoli, they start to replicate. And during the time when the host is developing an immune response to these organisms, the organism even has an opportunity to disseminate to other parts of the body. Then what happens is that you develop a sophisticated immune response to contain those organisms, and think of this as a granuloma, and those organisms stay captured in that granuloma. However, later in life or at some point in the future, those granulomas can break down and the organisms can escape control. So that's sort of the cartoon version. If we elevate it a notch, this is what actually is happening. You have all kinds of immunologic cells that are important in what's going on. So what can happen is that you initially don't develop a very good response, and that initial infection is not contained, and that's what we call primary tuberculosis, generally occurring in the first year or two after you've been infected. Then what we think of as secondary or reactivation disease occurs later on in life, when those granulomas that are containing the organism start to break down and the organism escapes control. All right, so what does this mean? How do we summarize this? Well, first of all, somebody who has a positive tuberculin skin test or a positive IGRA test, such as a quantiferon or a T-spot test, what this means is that you have T cells that recognize tuberculosis as something bad. It's a marker that you have an immune response to TB, and you only develop this if you've been infected. So a positive skin test or an IGRA test is a marker of infection with tuberculosis. About half of your lifetime risk after you're infected of developing TB disease occurs in those first 2 years after you're infected. Some people are more likely to do that if you're immunologically weakened. Certain genetic features may be related. Certain TB strains may be more virulent. And we know that age is very important. For example, infants who get an infection are much more likely to get sick than older individuals. So after those first 2 years, your risk decreases, and then you have a small but lifelong risk of developing TB disease throughout the rest of your life. And that risk can change if something happens that weakens your immune system. For example, you contract HIV infection, or you get put on a TNF antagonist to treat rheumatoid arthritis or psoriasis, or you get chemotherapy for cancer. All of those things can increase your risk of immune breakdown. It doesn't happen much in the United States, but theoretically you can be reinfected with tuberculosis, although it doesn't happen very often and mostly only occurs in people who have a weakened immune system. All right, so what do we mean by latent TB infection? Latent TB infection is infection with tuberculosis, but no symptoms or radiographic evidence of TB disease. Okay, so we know we have tests to tell if you're infected that we'll be talking more about, but you're not sick and your x-ray looks fine. And it's estimated that in the United States, up to about 4% of the population have latent TB infection, anywhere from 9 to 13 million people. So a lot of folks in the United States. All right. So now we think about latent TB infection and TB disease as either A or B, but it's not like that at all. We have some people with latent TB infection who actually probably somehow managed to kill off of all of their infecting tuberculosis organisms by themselves. And those people, even though they'll have positive tests, are never going to develop tuberculosis, TB disease, because there are no organisms left. There are also some people with latent TB infection who are on the other side, who have already started that path towards developing disease, and so they have sort of early or subclinical disease. The problem is that our tools just identify all of these people as identical, and it would be nice if we had better tests that would tell us, well, who has latent TB infection and is never going to get sick, and who has latent TB infection and is most likely to get sick. But our tools just don't help us with that. All right, so now you know all about the natural history of tuberculosis. Let's talk a little bit about TB disease epidemiology and how that figures out into what we do. All right, so let's start globally. We know that the estimates are that about 1/4 of the global population has TB infection. And we know most of the time this is latent TB infection because we know there aren't that many people who are sick with TB. Now, we also know that about every year now, there are about 10 million new tuberculosis cases, but those numbers are actually on the decline. After peaking in the middle of the last decade, the rates of TB, of new TB cases, and the number of deaths due to TB, even in the HIV positives, who are probably the most vulnerable population, have been on the decline. All right, and all of that risk of tuberculosis is different. Not all countries are the same. If you look at this color map of the world, the darker the green, the higher the incidence of tuberculosis. So the United States is considered a low TB incidence country. Less than 3 new cases of tuberculosis per 100,000 population per year. And even within that low incidence range, we are at the low end of the low incidence range. Mexico is considered low incidence as well, even though their rate is probably about 5 times that of the United States. But if you look here in sub-Saharan Africa or in parts of the Pacific, the rates of tuberculosis are at least 100-fold higher than they are in the United States. And so you have to think about people's risk factors of where they come from when they come to the United States. So let's focus on the United States, because obviously that's where we are. This is the figure of reported tuberculosis cases in the United States over the 25-year period, or I guess this is a longer than 35-year period from 1982 to 2017. And you can see that even before the period in the mid-90s, the rate of tuberculosis in the United States was on the decline. We did see this giant hiccup during the late 1980s and early 1990s. And this has been attributed to a couple of things. It has been attributed, one, to the HIV epidemic and an upswing in TB in immune-suppressed populations. And it's also been attributed to the fact that the public health response to tuberculosis had sort of dwindled during this time and had to be reinvigorated. I put this mark here because that physician that we talked about in the first case, that 62-year-old physician with the positive skin test, is me. And I converted my tuberculin skin test during my internship in New York City in 1982 during the early years of the HIV epidemic. But you can see that since things got back on track, the rates of tuberculosis have continued to decline. And in the United States in 2018, we had only about 9,000 cases, sort of the lowest number of new cases ever seen in the United States. So what does all this mean? All right, so if you think about the world, you can think about it as high TB incidence areas and low TB incidence areas like the United States. High TB incidence areas are often, not always, but usually resource-limited countries. They have lots of TB disease. They have many people who have TB infection. Those are countries where that percentage of the population that's infected could be 25, 30, or even 50%, and they see a lot more cases of TB disease than we do. The strategy in countries like that is to treat TB disease when you find it and treat some of the highest risk people who are TB infected, but they don't do a lot of screening for TB infection because they're still trying to control TB disease and then eventually eliminate it. We, however, are in a different period of our response to tuberculosis here. We are a higher resource country that sees very little TB disease and have some, but not a high proportion of the population that are infected. our strategy not only is to treat TB disease and those who are highest risk infected, but now we really think that we should be treating everybody with infection, because the goal here is actually elimination of tuberculosis. And we'll talk about why we think that is achievable. All right, so what does this mean for you as a primary health provider? All right, so there's less than 10,000 cases of new cases of TB disease every year in the United States. What does that mean? It means the new primary care physician may actually never see a case of TB disease in their entire career, because there aren't that many cases around. Even the average pulmonary or ID specialist might only see a single case of TB disease within a year. All right, on the other hand, we know that there is maybe 13 million people with TB infection in the United States. So new primary care providers will definitely see patients with TB infection during their careers. Now, just a little more about the epidemiology of TB in the United States, since most of us on this webinar are in New Jersey. And we want to focus on what we know about New Jersey. New Jersey, on this map, New Jersey is a dark blue state. And in this instance, it has nothing to do with politics. It has to do with the fact that dark blue states have higher than average rates or incidence of tuberculosis cases compared to the rest of the United States. And New Jersey's rate is slightly higher than that of the rest of the United States. New Jersey has, on average, the last few years, a little bit under 300 cases of tuberculosis every year. And you can see from this map that even within New Jersey, those cases are not evenly distributed. If you practice in Salem County, there's very little TB disease down there. Whereas if you practice in the core, where there's a huge immigrant population from countries where people have higher rates of tuberculosis, such as Middlesex and Hudson County, you'll see much, much higher numbers of cases of tuberculosis. All right, which brings us to this trend here. You can see that in New Jersey, the reason why we are a higher TB incidence state is that we are a higher immigrant state. And of the cases of tuberculosis in New Jersey, more than 80% of the new cases last year were seen in immigrants. And this brings us to what has been the most dramatic trend in tuberculosis over the last 25 years. On this curve, this is total number of cases broken down into people who were born in the United States and people who were born outside of the United States. And you can see that the green bars have continued to steadily decline. 25 years ago, the majority of cases were born in the US, but that is no longer the case. Less than a third of new cases were born in the US. The number of non-US born cases, however, although it's declined a little bit, has not really appreciably changed, okay? So what does that tell us? A lot of cases are born from people outside of the United States. And if you look at when those people get sick with their TB, it's not right after they arrive. A lot of them get sick much later in life after they've been here for a long time. So you can see that some people get sick 10, 20, or more than 20 years after their arrival in the United States. So they are TB infected, and later that TB disease wakes up. Right? We have one other interesting piece of data that also tells us about where most of the TB disease in the United States comes from. This is actually from also from the most recent epidemiologic slide set from the CDC about TB disease. Everybody who has tuberculosis now, who grows a strain of tuberculosis, they do fingerprinting on that strain. And by doing that fingerprint, they can identify who as part of a cluster, which means there's been recent transmission of disease, and whose strains are not part of a cluster and probably unrelated and reflect old TB that became active. And as you can see from this figure here, only 12% of tuberculosis cases where they grew an isolate are from what we think are recent transmission, and all the rest are from people who had TB infection at any point prior and then developed TB disease. All right, so we have a lot of natural history and epidemiology data. What does all this tell us? First of all, there's not a lot of TB disease in the US. We're a low incidence country. And from what I've shown you, most of the TB disease in the US is not because people are newly infected, but it's because they have latent TB infection that becomes active. So if we focus our attention only on treating people with TB disease and their contacts, we're only going to go so far in decreasing that total burden of TB disease in the United States. And the only way that we're going to eliminate TB is to do a better job in treating TB infection. So should we be looking for those with TB infection, and should we be treating them if we find them? And who should be doing that? Okay, so that is the question: should primary care physicians be screening for and treating latent TB infection? All right, well, this is 2 years ago. For the first time, the U.S. Public Health Service Task Force came out with recommendations that actually said that screening for latent tuberculosis infection in adults is a reasonable thing to do. They actually gave this a grade B recommendation. And what that means is a grade B recommendation is something that should be done and is actually something that should be funded by healthcare plans that are supposed to provide basic preventative services. So what they actually said is that we both have moderate benefit, the tests are good enough to help us, and that there's moderate benefit in preventing progression from latent TB infection to active disease, and the screening and the harms of screening and treatment are small. Therefore, this is something that we should be doing. And I added this caveat here that we should be screening for latent TB infection in populations at risk. All right, so this raises the question, how do we identify those who have TB infection? All right, so we have a healthy 19-year-old born in Peru who came to the US 2 years ago, and he needs a TB test to start classes at the local community college. So what's the best test to diagnose infection with Mycobacterium tuberculosis in this individual? So let's use this to talk about TB tests. The tests that we have to offer. So when we think about TB testing, we have to think about two different types of tests. We have tests that we use to diagnose TB disease, and those are the things when we send for people when we have people cough up sputum samples, and we send for smears and cultures, or we do DNA probe-based tests, and we look at chest X-rays. We're looking for TB disease. However, if you want to diagnose TB infection, our tools are the Mantoux tuberculin skin test, or TST, that we commonly call a PPD, which is a marker of delayed type hypersensitivity reactions in people who have TB infection. And the other tests that we have available to us now are the IGRAs, which include the QuantiFERON TB Gold test and the T-Spot TB test. And these are blood tests that measure interferon gamma that's produced in response to TB antigens. So let's start. So I think it's important to understand that these tests really are both measuring the same thing, but in different ways. In both of these tests, you are presenting antigens of tuberculosis. You're looking to see if people have memory cells that recognize TB as something they don't like. And this results in an immunologic response and production of cytokines such as interferon gamma. So in the skin test, you're poking the antigen directly under the skin, and you're looking for a welt, which is a measure of an immunologic response that includes interferon gamma. In both the quantiferon assay and the T-spot assay, what we're doing is we're taking their blood out, we're adding TB antigens in a test tube, and we're looking to see if interferon gamma is produced in a test tube. And this is obviously a positive skin test reaction. This is an ELISA where you actually look at color in the well, and that's how the quantiferon is done. And the ELISA spot, which is what we now call the T-spot, actually counts little spots of cells that are producing interferon gamma. But both of these tests require a functional immune system in order to be able to produce that response. All right, so let's talk about the tuberculin skin test and why we hate them so much. First of all, some of us don't know how to place them properly. Many of us don't know how to read them properly or are unsure about what we're seeing. This picture here, this is actually a woman who had a tuberculin skin test placed last week, and the color is slightly off, but you can see that is a huge positive reaction. That is an easy one to read. They don't all look like that. They're much more subtle most of the time. And the problem is the criteria for a positive may vary depending on what somebody's risk group might be. We see lots of false positives. The most common reason is BCG vaccine, but also infections with other mycobacteria. And we also see lots of false negatives for a whole variety of different reasons. We sometimes run out of skin test reagent, and right now we have a shortage of one of them. But the biggest reason why we hate tuberculin skin tests is that when we put them on our patients, they never come back to get them read. And that means you've just done something and you have no results. All right, just a little bit about BCG. So BCG vaccine is a modified derivative of Mycobacterium bovis, which is a close cousin of TB and actually causes some of the TB disease that we see. And it's given because it prevents overwhelming TB disease in young children who are infected with tuberculosis. And it's still administered in almost 160 countries worldwide, although not in North America, Western Europe, or in Australia, but throughout many other parts of the world, it's still widely used. The effect of BCG wanes over time, so although it may give you a positive skin test, the longer it's been since you've had it, the skin test is less likely to be positive, but it still might be. And that's the reason why anyone who's had a BCG vaccine, really the appropriate test to do is not a skin test, but an IGRA test. Okay, this little chart here just shows you what I mean. If you are age less than 1 year old and you are infected with TB, let's say there's somebody in your household who has active TB, you have a 35% chance that you will develop pulmonary tuberculosis and a 15% chance that you will develop disseminated tuberculosis, including meningitis, if you are infected in the first year of life. And that's why the BCG vaccine is so important if you're in a country where you're going to be exposed to tuberculosis. All right, so we don't like skin tests. What about IGRAs? Do we like them any better? Well, we've already talked about how IGRAs work. You take blood out, you add TB antigens, and it relies on the fact that you have T cells and antigen-presenting cells, which are usually macrophages. And in the test tube, something happens when your T cells see TB and they don't like it, and you produce interferon gamma. So this response is generally driven by CD4 cells, but also CD8 cells in the newest version of the quantiferon. And you can have a positive, a negative, but you can also get an indeterminate, which is pretty common with the quantiferon test. So let's look at the report of a quantiferon test and try and understand what all these numbers mean. So probably the number that you're most interested in is the top. Is this a positive or a negative test? And this is a positive. All right, but buried within that positive are a couple of things. So these numbers here, the nil result is your background. So that means that if your nil result is too high, there's a problem with the test. So a nil result should be low. A mitogen is a non-specific measure of your immune system. If somebody has a functioning immune system and they're exposed to mitogen, they produce interferon gamma. And so you want to have a positive response to the mitogen. If you don't have a good response to the mitogen, then that's the most common reason why you have an indeterminate test. It's not because the test is maybe mildly positive, it's because your immune system is too weak for this test to be reliable. All right, and then you have the T-spot has two different assays, the TB1 and the TB2, and if either of these gives you a positive result, then it's interpreted as a positive test. So the most important thing to remember is that an indeterminate test doesn't mean that you are likely to be positive. It just means that because your mitogen value is low, it doesn't tell us anything. It's the same thing when we place a PPD on somebody and we say they're anergic because they don't respond to anything. It's neither positive or negative, it's just not helpful. All right, so let's go back to our gentleman from Peru. And which test are we going to do? And we already talked about the fact that he is from Peru, a country where they do give BCG. And we're going to do a IGRA type test, either the quantiferon or a T-spot. But then this begs the question, what are you going to do if you find infection with Mycobacterium tuberculosis? What are you going to do if he has a positive test? Which gets back to, in order to answer which test do we do, why are you doing the test, and what are you going to do with that result? All right, so let's get back to what the Public Health Service is telling us what we should do. It's telling us that we should be screening for latent TB infection in populations at risk. Okay, that doesn't mean that we should be screening for latent TB infection in everybody. All right, so let's talk about when, but also how to test for TB infection. We're going to, obviously, if somebody has TB disease, a quantiferon or a skin test may be useful to help us in the diagnosis of TB disease, but those tests may be falsely negative if you're sick. More commonly, we do testing for latent TB for TB infection in people who were trying to find latent TB infection. But who is that? So is it somebody who's got higher risk of having TB infection? And most of the time, that's somebody who comes from a high TB incidence country, or perhaps they happen to be a contact of a case. Or is it a population, even if their risk of having TB infection is low, they are at very high risk for developing TB disease, like somebody who has HIV infection or who you're planning to treat for their rheumatoid arthritis with a TNF inhibitor. The other thing to think about is what is the likelihood that if you test them, you're going to get a false positive result. So that's the reason why we would never do a tuberculin skin test in somebody who's received BCG, because we won't know what to do with the data because there'll be a lot of false positives. So which test should we do? IGRAs are always preferred in people who've had BCG, and from a practical perspective, they're preferred in everybody who you think is likely not to return for their skin test. Our rate of return in our HIV clinic when we were doing annual TB testing in all of our HIV folks was only about 50%. So we have now switched to uniform IGRA testing in our clinic because we don't have to rely on the delays involved in failure to return and then having to repeat the test. The tuberculin skin test is still preferred for children who are less than 5 years of age, but IGRAs are actually usable and can be used down to as low as 2 or potentially even younger ages. The problem is that we just don't have quite as much experience with IGRAs in younger children, so we don't know what the false negative rate is. Under most other circumstances, you can do either test, but I will tell you that the way of the world is that IGRA is becoming the preferred test under most circumstances and is considered preferred if you are testing a group that's more likely to have TB infection and a group that is going to have higher risk of progression from TB infection to TB disease, which really means most of the people that we are testing, unless you're just doing population-based screening, such as people who need to be tested for certain occupations, most of the people that we are testing fall into either higher likelihood of having infection or higher likelihood of progression, and the IGRA is the preferred test. We generally don't recommend doing both tests, but there are some instances where we might do both. One is if we're worried that we have a false positive result in somebody who has no reason to have a positive test. And the other would be in a really high risk group where we want to improve our sensitivity. All right, so what the TST and IGRA can and can't tell you. They're useful epidemiologic tools. As we've already talked about, you can't tell if a positive IGRA means that you are have latent infection or TB disease until you do a further evaluation. If you have a negative IGRA, it doesn't mean that you don't have TB disease if you have symptoms, because sometimes people who are sick aren't able to mount a positive test result. The other thing to realize is that neither of these is a perfect test. And so if you think about this purple circle here as everybody who has TB infection, skin tests will pick up many of them, but not all of them, and will pick up some extra people who have BCG, vaccination, or other false positives. There aren't as many positives with an IGRA, but an IGRA will still miss some of them. And the two tests, although both of them are pretty useful, are not entirely concordant. The other thing about both of these tests is they don't turn negative if you've treated somebody. So they can't be used to follow what happens to you. We think, although it may not always be the case, if you're positive, you're going to be positive for life. All right, so let's go back to our young gentleman from Peru. His IGRA is positive. What do we do now? So what does a positive test mean? What are the clinical parameters of latent TB infection? We know what latent TB infection is by definition, but clinically, what does that mean? So it means that they have a positive tuberculosis test, either the skin test or an IGRA, and they have a negative chest X-ray and no symptoms or physical findings to indicate active tuberculosis or TB disease. So what does that mean? It means that when you get that test result back, unless you've evaluated the patient, you can't tell whether or not they have TB disease, although just by numbers, the vast majority of them do not. But you really can't fully tell the significance of a positive test until you've done that further evaluation. All right, so how do we evaluate those with a positive test? What are we trying to do? Well, the first point here is pretty obvious. If you're not going to do anything about a TB test, then why did you bother to do it? Don't do it unless you are prepared to then go ahead and treat that individual. So that doesn't mean you should be afraid about treating them. It just means that what is the purpose of doing the test? Now, if you have a positive test, what are the goals of your evaluation? We know that a small number of people with a positive test actually have TB disease. And obviously, we want to find those people because if they have TB disease, we want to treat them. But the vast majority of people that you will see who come to you with a positive test don't have TB disease. So we want to kind of look at our population and sort of do this as a risk-benefit analysis. We want to identify those people who have latent TB infection and who have higher risk of progression to TB disease because those are the ones who are going to benefit most from treatment. But we also want to identify those who are at the highest risk of having poor outcome if we give them medicines to treat their latent TB disease, either because they're going to be non-compliant or at highest risk of toxicity, and then we're balancing these two factors. But as we will talk about when we talk about some of the newer treatment regimens, almost all the time now, the benefit of treatment for latent TB infection outweighs the risks in most individuals with latent TB infection. All right, so this is the schema, again, from the CDC of how we evaluate someone. We rule out TB disease. We consider latent TB treatment, which we're going to consider pretty much in everybody. And then if somebody accepts and is able to receive treatment, we're going to develop a plan of treatment to ensure their adherence. If they refuse treatment or is unable to receive treatment because the risk outweighs benefit, then they no longer need to be followed by any kind of serial monitoring of either x-rays or skin tests or IGRAs. What they need to know about and they need to be followed for are the signs and symptoms of TB disease. All right, so how do we evaluate for TB disease or active TB in somebody with a skin test? We're going to do a chest x-ray, a brief history, and an exam. And most of the time, not much else, if all of those are normal. However, if somebody's got a cough or an abnormal x-ray, then you might have to do testing to exclude active TB disease, which is where sputum smears and cultures come in. As a primary care physician, if you have concern for TB disease when you do your evaluation, the one thing you don't want to do is start to treat for latent TB infection if you are at all worried about active TB. If you treat somebody with active TB with a single drug for latent TB infection, those people can develop resistance to that drug. And it's never an emergency to start latent TB infection. And if you're not sure, this is where you should get help. And we'll talk at the end about where you can get that help. All right, so we talked about people who are at risk for developing TB disease from TB infection, and they fall into two categories. One is people who have been recently infected, such as contacts of an active TB case. Those people, because they're still in that first 2-year period when they've been infected, have a lot of that, half of their lifelong risk is going to happen in those next 2 years, so they're at high risk for getting TB disease. The other group that we presume to be recently infected are children, just because they haven't been around long enough to have been infected a long time ago. And the second pool are those with clinical conditions that increase their risk of progressing from latent TB to TB disease. All right, so recently infected include case contacts, skin test converters, kids, and maybe a few other groups. Since I know a number of you see kids as part of your practice, and since we are sponsored by the American Academy of Pediatrics, I think just a word about TB, pediatric TB in the US. Now, remember, we talked about the fact that most cases of tuberculosis in the US are in people who are born outside of the US. That's not the case for children. The vast majority of tuberculosis cases in children are still born in the United States. You can see the blue bar here is US born, and the orange bar here is non-US born. However, if you actually look at them, most of those kids are actually are members of often immigrant families and have household contacts with tuberculosis, and that's where they acquired their TB disease. And that's different than the epidemiology in adults. All right, so we talked about risk factors for progression from TB infection to disease in adults. And you can see here, this is just a table that tries to risk stratify. One being somebody with average risk of progression from latent TB to active disease. You can see the highest risk factor here is advanced untreated HIV infection or being a close contact of an infectious TB case. However, there's a lot of other risk factors here, and many of them have risks that are twice or threefold higher than the average in the United States. We worry a lot about people who are getting TNF-alpha inhibitors, but those people really only have 2 to 3-fold higher risk than average of progression to TB. I want to focus, however, on diabetes, because if you actually look at the numbers of cases in the United States, about 20% of 2018 US cases of tuberculosis had diabetes, many of them poorly controlled. So we know that diabetes, even though it's not a huge risk factor in terms of magnitude of risk, is a huge risk factor in terms of the number of individuals with tuberculosis in the US whose only risk factor might be diabetes. All right, so one of the tools that if you're having patient discussions that you can use to help with your discussions of patients is there's actually a tool by McGill University called the Online TST IGRA Interpreter. And what it is it's a way of taking data from a patient, including either their skin test size or their IGRA results and some other epidemiologic factors and other health conditions, which are listed. I didn't show that on the slide. And it tells you with that information what this individual's likelihood is that it's a true positive test and what their lifetime risk of developing TB disease is. Now, this risk calculator, unfortunately, only talks about toxicity from isoniazid and when it talks about risk of treatment. So I think that it probably needs to be further modified. But if you're talking to an individual patient about what their risk of developing TB disease is, it's a useful tool that may help you with some of those discussions. All right, so back to our case. Our 19-year-old from Peru with a positive IGRA, a negative chest X-ray. Should he be treated and with what? So while we're thinking about him, here's another case. This is a 62-year-old from the Philippines with psoriatic arthritis who's about to be started on a TNF inhibitor, and he has a positive IGRA. He has a negative X-ray and no symptoms. Should he be treated? And let's go back to our 62-year-old US-born physician with a positive skin test and a normal chest X-ray. His IGRA is positive too. Should he be treated? And what will we treat him with? So let's spend the last few minutes of this webinar talking about treating latent TB infection, what our options are, and how we monitor. So when we think about treating latent TB infection, we can think about a couple of things. One is we want to use a regimen that will work, meaning that if we give it, it will decrease their risk of progressing from latent TB infection to TB disease. Second, we want to know if the regimen is safe. Is it something that doesn't add much toxicity? But the third thing that's equally important is how likely it is that the treatment regimen course will be completed. With safer and shorter regimens with higher completion rates, benefit outweighs risk in most with latent TB, and we know the completion rates are always higher with shorter rather than longer courses. So we're trying to take that benefit and make that benefit as high as possible and keep that risk as low as possible. So what are the treatment regimens for latent TB infection? From the CDC and the US Public Health Service, we have a couple of regimens now. So the old regimen that you're all familiar with is isoniazid. And the abbreviation for that is 9H or 6H. Traditionally, it's given for 6 months, and almost always we give it daily. It's only given twice a week if you can do that under directly observed treatment. However, we're happy with 6 months most of the time because you get most of the benefit. You get about 80% of the benefit of 9 months of treatment if you can get 6 months of treatment in. So that's considered okay in adults, not so in kids, okay? What other regimens do we have? Well, the new regimen that is equally effective to isoniazid is the once weekly 3-month regimen or 12-week regimen of isoniazid plus rifapentine. So you take your pills 1 day a week and you take them for a total of 12 weeks. The other regimen that some of us have been using for a long time is rifampin, or 4R, and this is also a daily regimen. Excuse me 1 second. And you take that for 4 months daily. So all of these regimens are effective. And by what we mean by effective, most effective would be up to 90% decrease in the risk of developing TB disease. And we know that the more adherent you are with the regimen, the better the effectiveness. So if you actually take all 9 months of your isoniazid, then that correlates with 80 to 90% decreased risk of TB disease. Isoniazid is preferred in young children, and it is considered preferred in HIV infection on antiretroviral therapy, mostly due to drug interactions of the rifamycin. We know that the shorter regimens have significantly higher completion rates and decreased hepatotoxicity. All right, one thing about the 3HP regimen that is new, when this regimen was first introduced, it was introduced as a regimen that had to be administered by directly observed therapy. So somebody would have to come into your office once a week and you would watch them take your pills. It has now been approved to be given without directly observed therapy, and that's obviously much less burdensome on the healthcare providers. Most of the time, we like to give the first or at least the first 2 doses under directly observed conditions, but then after that, the patients can take it on their own. We also know that there's better evidence now for 4 months of rifampin, so all of these regimens are considered comparable in efficacy. The biggest limitation to any regimen that has a rifamycin in it, which is either rifampin or rifapentine, is that these drugs interact with lots of medicines in terms of increasing their metabolism. The net result of that is that elderly patients on multiple medications, you have to be careful and look at drug interactions if you're thinking of using these drugs. All right, this slide just shows you the dosing. I'm not going to go over this. You can all look this up. But the adult and pediatric doses for all of these different regimens are included on this slide. All right, so what's new? We already talked about self-administered once-weekly isoniazid and rifapentine. And although the completion rate with directly observed therapy was about 85%, the self-administered folks had at least 75% completion rates, which is much, much better than the completion rates that we typically see with isoniazid therapy. All right, so let's talk about laboratory monitoring. So we don't necessarily think that everybody needs to have baseline liver enzyme testing. It is recommended for patients with any of the following factors: those who have liver disorders, who are at risk for liver disorders, or a history of liver disorders, and that includes Hep B, Hep C, alcoholic hepatitis, cirrhosis, people who drink regularly, people who are HIV infected, and pregnant and postpartum women. However, you can think about doing baseline testing on an individual basis for other individuals, and we almost never recommend baseline liver testing for pediatric patients or adolescent patients unless they have an additional risk factor. All right, so the risk of isoniazid hepatotoxicity, if you're using it, increases with age. Rare under 20, up to 2% as you get older, over 50, but higher if you add in other liver toxins. However, it's common to see mild liver enzyme elevations early in treatment that don't require stopping your treatment. When we monitor people on isoniazid, we monitor for signs of hepatitis as well as signs of neuropathy. We laboratory monitor only in those who are at higher risk for hepatitis, but I will tell you from a practical perspective, the other group that we monitor in our clinic is anybody who we don't think symptom assessment is going to help us tell if they're getting into trouble. And that includes people with language barriers, people with dementia or psychiatric issues. And there are certain hard stops as to when you want to stop isoniazid if they're on treatment. And we can give pyridoxine to prevent neurotoxicity with isoniazid, but generally we only do that in people who have poor diets or in postpartum women. All right, and this just shows you what's important here. This is the trial comparing 9 months of isoniazid with 3 months of isoniazid and rifapentine, and you can see the main thing here is the risk of hepatotoxicity is way, way less with a 3-month isoniazid rifapentine regimen. And if you look at 4 months of rifampin versus INH, again, the risk of hepatotoxicity is much, much less here if you are taking the 4-month rifampin regimen. So less hepatotoxicity and higher completion rates. Sounds like a win-win. All right, so key points. Most TB disease in the United States is from reactivation from latent TB, and the only way to decrease the burden of TB disease is by treating latent TB infection. The U.S. Public Health Service endorses screening in selected populations and treating if you find it. Both tuberculin skin tests and IGRAs can be used for screening, but if somebody's positive, you can't just stop there. You have to do something about it. And IGRAs are preferred if you have a history of BCG or you're not going to come back to get your test read. And we have newer, shorter, and safer regimens, including 3 months of weekly isoniazid and rifapentine and 4 months of daily rifampin that are available for treating those with latent TB infection. All right, where do you get your help if you have TB-related questions? So 2 places. The map on the right is a map of the regional TB clinics scattered throughout New Jersey. We are the regional TB clinic in Belmar, and we obviously the only one in the southern part of the state. And we are always happy to take questions from anybody about managing TB-related issues, including latent TB infection, or whether somebody needs to be further evaluated, or you're worried that they might have TB disease. The other place you can look is the Global TB Institute is one of 4 centers of excellence in the United States for training, education, and medical consultation. And this is their number. And we, who are the consultants from the Global TB Institute, are happy to take your phone calls and take any questions that you may have about management of either TB infection or TB disease. And we will stop there, and let's look and see if we have any questions. We'll give you a chance, if you have questions, to pop them in. So nobody has any questions? Everything is crystal clear?
I think at this point, since we have no questions, we can conclude our webinar. If there are any questions that you may have after the webinar has concluded, you can feel free to email them to njchapter@njaap.org, and we can pass them along to Dr. Fraimow to be answered. So on behalf of the New Jersey chapter of the American Academy of Pediatrics and the Rutgers Global Tuberculosis Institute at the New Jersey Medical School, we would like to thank Dr. Fraimow for presenting this specific topic and for everyone joining us in the webinar today. Thank you and have a great day.